He completed his residency at the Menninger Clinic and has had a private practice for the past 15 years. Today, he's an adjunct professor at Tufts Medical School, Department of Psychiatry, and he served as an associate faculty member at the Austin Presbyterian Seminary and has begun studies at Harvard Divinity School this fall. And I'd like to welcome Dan. And I also want to welcome Dr. Sidney Hankerson. Sidney has been one of our panelists also in the past, a speaker at Pathways to Hope. He is a psychiatrist at the Columbia University Medical Center and co-director of the Columbia Wellness Center. He is a nationally recognized expert in strategies to reduce depression and stigma among African Americans and engaging Black churches in mental health promotion and treating Black men with depression. He was a featured speaker at President Obama's White House Dialogue on Men's Health and White House Making Healthcare Better series. He currently serves on the NFL Behavioral Wellness Committee, lives in Manhattan with his wife and 2 daughters. So welcome to you all today, and we're going to open this up to questions, and we'll all be watching the Q&A to see what questions come into us from the audience. And I'll look at both Q&A and chat. People kind of go back and forth on that. In the meantime, while we're waiting on questions to come into us, would you all like to say a few things to begin?
Well, I will start out and just say this, that some of us at conferences like this deal with mental illness personally. Some of us have family members, and some of us are clergy or mental health professionals that deal with it in our work. And it just so happens that I'm personally in all 3 groups. I deal with it myself, and I have family members who deal with it. And I have the privilege of working with it every day. So, and I'll bet Dr. Hankerson feels the same way. I never feel like I'm talking down to anybody. I feel like we're all in the trenches together dealing with this, and that's just a reality for me.
Yeah. Thank you for that, Dan. I'll just echo Dan's sentiments about the privilege it is to be here. And I am certainly someone that has been impacted by mental health conditions in my family and personally. I tell people who work with my team, as well as the pastors and community members and families that I work with, that I see a therapist every single week. And so I think it's one of the most important things to do. And we're really here to serve and to answer questions that you may have, because there can be so much uncertainty about mental health conditions. So we're really excited to be here today.
Okay, we have our first question. What are your thoughts on ketamine therapy for treating depression?
You want to go up first, Dr. Hankerson?
Sure, I'll go. So just to give some context, so ketamine is one of the newer FDA-approved treatments for depression. It's approved for what we call treatment-resistant depression. So it is for individuals who have had at least 2 prior depressive episodes, and they have taken at least 2 different types of antidepressants. And even after taking those 2 prior antidepressants, they still have significant depressive symptoms. And so ketamine is reserved specifically for what we call treatment-resistant depression. It has been used classically initially as an anesthetic. And so it is reserved for use in clinical settings. So you have to go to either, an outpatient clinic, and it can be infused in one of 2 ways, either intranasally or intravenously. And the data on ketamine is actually very impressive in terms of reducing depressive symptoms and helping people feel better very quickly in the outpatient setting. And so I think that for folks who have treatment-resistant depression, it can be a very effective treatment, very acutely at improving depression. I think what we still need to find out is how effective it is kind of long-term, but that's kind of my take on ketamine.
We have a question here from Dr. Kemp's wife. How can we as a Black church move towards being more open about mental health issues in our community and our church? Dr. Hankerson, I'll let you take that one.
Sure. I just wanted to see if Dr. Morehead wanted to add anything to that ketamine before responding.
I was just enjoying the quality of that summary. I would agree with that totally, and say I'm personally so grateful that we have it, because there is a lot of treatment resistant depression out there and a lot of people who've been suffering for so many years. It's not a cure-all. There's probably not ever going to be any medicine that's a cure-all for everything. And so it doesn't work for everybody. And even when it works, as Dr. Hankerson said, sometimes we still have to figure out, well, what do we do long-term to stay out of depression? And luckily, we have a lot of tools for depression, like talk therapy and exercise helps and other medicines. But yeah, ketamine looks very powerful, and it works in a different way from anything else we have. So happy that it's out there and getting more available.
Okay, thank you. And let's go to that question, Dr. Hankerson, on how can we as a Black church move towards being more open about mental health issues in our community and church?
Well, I think I'll speak just generally about faith-based organizations, and then some specific things about faith settings in the African American community. And Dr. Morehead has a lot of expertise in this area as well. So I think that one of the biggest things in the African American faith-based settings is to realize that the church has been a home of providing informal supports and counseling for centuries. People go to their pastors when they're seeking support for depression and grief. There are bereavement ministries. There's Celebrate Recovery, which help people with addictions. And so, our churches are really kind of what my pastor says, hospitals for folks who need healing as it relates to mental health conditions. And so I think in the African American community, where there has traditionally been distrust or lack of access to traditional or formal psychiatrists or mental health services, the role of the church is especially important. And so things that we have found that have been successful in engaging Black churches to promote mental health is, number one, having the support of the lead pastor. So at the churches with whom we've worked, pastors talk on Sunday morning in scriptures and talk about how depression was in the Bible and the importance of getting therapy. They also talk about the importance of both spiritual practices like prayer, like exercise, and using a holistic approach, and seeking therapy. And so I think one of the most powerful strategies has been our pastors being really leaders in supporting this effort. And then the second thing I'll just highlight is that we have created, in partnership with Church Health Ministries, programs where church leaders in the health ministries can become community health workers. And so again, that's kind of a peer-based model where leaders in the health ministries are able to identify people with depression, provide brief motivational interviewing, and then connect them to formal services. So pastor support and then using trained leaders in the church has been a real strength, I think, of leveraging the Black church.
Thank you. It reminds me a lot of what we're doing in San Antonio with Bridges to Care. I want to direct the next question to Dr. Morehead. Is there any current research or any to come that will address how to deal with individuals with anosognosia? How can I help my daughter understand that she is ill and needs help?
So this is one of the, I think, most painful things we deal with in mental health. And it's something, and I know Dr. Hankerson and Doug have had the same experience. It's something that comes up repeatedly in every conference like this that we do, that people are here, multiple people saying my son, daughter, spouse, parent clearly is dealing with a mental health issue, and they just won't seek help. They won't talk about it. They won't hear about it. It's excruciatingly painful. And as a loving family member, I know, and I've been in this position myself, you would take it on yourself rather than have someone you love suffer in this way and watch their suffering go on and on without getting help. And so I actually recently delivered a talk at a mental health conference on this very subject. And I went on for 45 minutes, and I had to admit I don't have the solution. And if Dr. Hankerson does, I'm taking notes, and I'm so glad this is being recorded. There are numbers of things to do and to try, but most people I've talked to, if they've been dealing with this for years, they've already tried it. And so in medicine, they talk a lot about the tincture of time, meaning sometimes things change over time. And I've known people who for years just wouldn't get help or wouldn't acknowledge a problem that finally did. So don't give up. I think prayer is huge if you're a person of faith, because it takes some of the burden off me. Like, I'm not God. I can't make somebody see something or realize something. And prayer helps remind me God has to be God. I can just do my little role as a family member. And then beyond that, one of the little sayings that comes back to me a lot in mental health work is called strike while the iron is cold. Meaning, when you have a difficult thing to discuss, especially with somebody that you're close to or in your family, and you know it's a hot button issue, the best time is when things are calm, right? Not in the heat of another argument where it comes up, and I've done this, and you won't even go in and see a doctor for X, Y, and Z. It's a natural time, but a better time is when everything's calm and we can sit down and talk with no distractions and just put it in as low-key a manner as possible if it's activating for somebody, and in as matter of fact a way as possible, and then ask as many questions as possible, right? What do you think of this? What do you think's going on? How do you understand this? And just go through a series of questions and ask what you're concerned about, and say, I love you and I want to do whatever is helpful. It's up to you, but I love you. And then finally, just not to go on for 45 minutes about this. There are times when we don't have a choice about calling somebody else in, and that is when there's any kind of abuse, be it violence or emotional or verbal abuse. We need to separate and get away from the situation as quickly as possible. And if we need to call 911 for somebody's safety, we don't want to, but we'll do that rather than have people be at risk for getting hurt or out of control. And that is a hard call, but you do that when it's necessary for people to stay safe. And then there are other ways to involve supportive others. If your family member won't get help, doesn't stop you from seeing a therapist, a doctor, a pastor, or especially NAMI. Family support groups are available, I think, online. Doug and Dr. Hankerson would know. So there is help and support, and there are thousands and thousands of people who've been in this situation who are able to be supportive.
I'm gonna move on because we have a number of questions. I will also recommend to that question, and the person who wrote this question knows about it, but Javier Amador's book, I'm Not Sick, I Don't Need Help. Really good guide. He's been a NAMI favorite, but he talks about exactly this anosognosia and how to deal with your family member. Let me move to a question. Would you please elaborate MDD with catatonia features? How effective are benzodiazepine and ECT? How long does the person with catatonia does it take to recover from mutism and immobility? How safe and effective is ECT in the treatment of catatonia? Dr. Hankerson, you want to take that one?
Sure. So yeah, this is taking me back to my residency days. So catatonia generally is a state of kind of immobility and what we call mutism, where typically the person doesn't speak. That's the most common condition. It also can involve restlessness or agitation, but we most commonly think of it where someone is not moving and where they're not speaking. And so major depressive disorder, or MDD, kind of with catatonic features, it's important to note that many psychiatric conditions can have catatonia. And benzodiazepines and or ECT are effective treatments for catatonia. I think the other question was about
How long does it take for the person to recover from mutism and immobility?
that really varies by person to person. It depends a lot on kind of treatment history, on other medical conditions that a person may have, other medications that they may have taken to treat their depressive history. There's a lot of factors that go into that, so I can't really comment on that. But both benzodiazepines and ECT are effective treatments for catatonia.
We have several questions related to, do you have anything to add, Dr. Morehead, to that?
Nope, agree with all that.
Okay, we have several questions. Dr. Hankerson, my son is a student at Columbia and has suffered from depression that came up during his time at school. This has not been recognized before he went off to school and has been exacerbated by the pandemic. He is back after being gone due to COVID. Do you have suggestions for how to support young adults away from home?
Wow, I think so many parents are struggling with this right now, and so many young adults. So I think one thing would be to get your son connected into, and this applies to everyone who has college age children, is to try to get them connected to their school's mental health services department, so that they can be under ongoing clinical care. I think that's really, really important. And then I think something for you could be something like the NAMI to family program. I think so many parents now rightly are anxious about their kids going back to schools and are struggling with the uncertainty of what COVID. So I think for you and your family, the family to family program can be really helpful resource as your son is transitioning back to college.
Dr. Morehead, anything to add? You've been through this too.
Sure have. Agree with all that, and thank goodness most universities have mental health centers or health centers and ways of connecting students with treatment, because it's hard, very hard when you're away from home. The first time I actually personally got depressed in my college years, and the other thing, which is it's probably too obvious, but I have to remind myself sometimes, if you're a parent, just the fact that you're out there and you care and you want to be in touch is huge. Now, you don't call them 18 times a day if it's not an emergency, but even if they return your messages sporadically, text or phone calls, just knowing that you're there and you'll help them and there's something to fall back on and there is a safety net is huge, and you should know that. And then the other thing is just to make as clear as possible. Let us know what you need. We want to help you without trying to control or be invasive. College students are so sensitive. I mean, at least I was, to to wanting to feel like adults and not be controlled. But on the other hand, to know that resources are there. Just say the word if you need more, and we'll try to help you get it. And then there are emergency services. Worst case scenario is you can walk into any ER at any time, 24 hours a day. They deal with mental health emergencies all the time. It's not your first option, but it's an option of last resort if somebody's suicidal or in some kind of life or death situation. There's always help.
We have a comment from a parent, says, at university, the mental health services are often overrun. Our experience is that our child could only be seen if she was already suicidal. Any comment?
Yeah, I mean, unfortunately, that really speaks to one of the challenges just in the U.S. in general that's really been exacerbated through COVID is just the bottleneck or the shortage of accessible mental health services. And so that often I do hear that from various colleges. And I think, Dan's points about making sure that you're available, that you're accessible, and that you're supporting your child Coming up with some type of safety plan, I think, is important, that you communicate and everyone in the family knows. And then, one thing is the good thing, if parents are able, youth are able to stay on their parents' insurance until 26. So there may be providers in that town that take your insurance that they could see that's not connected to their college or university, so that they could get the care, that they need.
I totally agree. And I also want to throw in, since getting treatment is such a big issue in general for college students, but pretty much everybody, there's a huge shortage of psychiatrists in this country and around the world. So it's hard to get into a psychiatrist, much less find a right therapist. But yes, be persistent. When Dr. Hankerson or I get a call, we know that person has been walking on hot coals. Ask everybody they know, call all the resources they know. Don't give up. It's very hard, but it's par for the course. So word of mouth, look at reviews on the internet, call your insurance company. They can help find people. They're supposed to help do that. And then you just keep calling. And if you don't hear back, be polite, but call again. Because not only mental health centers, but doctors' offices, therapists' offices are often busy and swamped too. And so you just keep calling back till you get an answer. And it's so terrible that people have to do that just to get care. It should not be that way, but it is. And so especially when you're in the role of a parent, that's one way you can make a big, big difference.
I'll also add, as a parent, having gone through some of this, when you have a child that is away and not living in the town that you're living in, it makes everything 3 times, 4 times more difficult. And sometimes it's hard to discern over, with a phone call or a Skype or whatever, kind of what's really going on. And so sometimes you just have to fold up the tent, go home, especially during COVID, get closer to where your support systems are. The other thing is that within NAMI, I know we trade information like it's nobody's business to find out who did you go see as a therapist or a psychiatrist. Those informal networks are absolutely critical. Let me go to the next question. My son has schizophrenia, bipolar 2. He was taking Prolixin for 15 years. He stopped because of breast enlargement. I noticed he's paranoid and his thoughts are scrambled. He's now taking Risperdal. So that's kind of a comment. Either of you all want to talk about this?
Well, I mean, it sounds so. Just to, I guess, give some folks some context. So, Prolixin is an antipsychotic type of medication, what we call a first generation, or it's an older type of antipsychotic that has been shown to be pretty effective. But based on what you're sharing with us, it sounds like your son is still symptomatic, having paranoid thoughts, having thoughts that are scrambled. Indicates that he's still having psychotic symptoms, and it sounds like his providers decided to switch him to a newer medication, Risperdal. Now, time will tell whether or not Risperdal is able to effectively kind of reduce his symptoms, and we certainly hope that. It is important for you and for your son to note that Risperdal also can cause kind of breast enlargement, and that can actually cause something called gynecomastia, or actually a discharge, from the nipple. So it's important to keep an eye on those type of symptoms, especially if he had those symptoms with Prolixin. It's possible, and some would say maybe even more likely, that it would happen with Risperdal.
Yep, absolutely. And just throw in here, and as you all can see, I kind of free associate on these things, but these questions are really good questions, and they bring up a lot of important issues.
Yeah.
So one is that as Dr. Hankerson was saying, there's an array of medicines out there, even in this category. So don't give up, because it's very common that people have to try several kind, and we can know when you try a medicine, hey, there's a 60% chance that this will help you, right? but are you in the 60%? We're not good at saying that yet. So we have to try, and if it works, great, and if it doesn't, we move on or adjust. And so, and then of course, the other part that I wonder if is involved in this question, cost of medicines is so high now, and especially for this class of antipsychotic medicines. They're actually medicines that we use for all kinds of conditions, depression, mania, and psychosis like hallucinations, but they are really expensive as a group. And so that plays into it. You know, we have to balance what can we do cost-wise with what insurance or Medicare and Medicaid covers, with the side effects and how well it works. And so Prolixin and Risperdal, they're not cheap at all, but on the scale of things, they're cheaper. And so that's probably one of the factors that everybody's trying to balance here. But the other one that really is very tangential, but I just got to put in a plug for this. I'm not an expert in community psychiatry or schizophrenia per se, but we know now that with some of these medicines, when it's hard for a person to take it every day, there are forms of a lot of them where you can get a shot every couple of weeks or every month. And of course, nobody likes getting a shot, but they've refined it pretty well, and it's not bad. And in studies, once people start doing it, they like it as well or better. And it works really well. Whereas with schizophrenia, even missing a few doses can have a disastrous effect. So this was not the question, but I'm still shoehorning in a plug for, you know, if you're having problems with your medicine and you're dealing with schizophrenia, consider or ask your doctor about an injected form of the medicine. It sounds bad, but it's actually better all around.
And to that point, Risperdal actually does have an injectable form of that, so that could be an option, you know, for your son.
Okay, next question. I'll send this one to Dr. Hankerson. I would like suggestions for helping Black pastors who don't support mental health and discourage use of therapists for assistance to understand the seriousness of the need.
You know, that's we could have a ask the doc just about that question right there. I think that the good news is that over the last several years, and I think especially over the last 18 months with the pandemic and with the rise of depression and anxiety in this country, and unfortunately, with the rise of suicide among Black youth, that pastors are becoming more and more open to encouraging people to seek mental health care. Many of the pastors with whom we work and partner are more clearly delineating the lines of spiritual support and growth and emotional and mental health support and growth. And so I think one of the things that you could do is just continue to be present and try to share stories of people of faith in particular, because I think there's often for faith leaders, there can be this notion of, well, if you just pray enough, if you trust God enough, if you have enough faith, then you'll be able to overcome whatever mental health challenge that you have. And we know that all of those spiritual practices are important, but mental health conditions are very disabling, very common, and to Dan's point, very severe and very real illnesses that take real and medical and psychiatric and psychological treatment. And so I think sharing, instances of people like the Rick and Kay Warrens of the world who talk openly about mental health, like NAMI FaithNet, Pastor Michael Walron in New York, who talks about having chronic pain and going to see a therapist. I think sharing those stories can help chip away at some of the stigma and the divide that faith leaders have with encouraging people to seek mental health care.
Yeah, I want to piggyback on that in a general way if I can, because that was so well said. And it reminds me of this story. I grew up in an evangelical tradition, and Matt Stanford, who also works with faith and mental health as a psychologist who works with those communities a lot, who said one time he was in a discussion group and a pastor who was very wary of mental health said, well, I don't want to use anything that Jesus didn't use, like a medicine. And so Dr. Stanford said, well, did you drive a car to get here today? And then he said he kind of regretted it because he didn't want to be so confrontive. But you know, with other conditions, and it's so hard, even as a psychiatrist, to get my mind around this. I say this to myself multiple times a week. Well, how should we think about mental health conditions? Well, how do we think about any kind of medical problem or illness, right? So if I or somebody in my family gets cancer, I really don't have a debate within myself of, you know, should I pray and read scripture or should I get some medical care? But it's just so normal and natural. Whereas if I have depression or bipolar addiction, you know, should I pray or should I take a medicine? And my feeling is that, you know, we know from the science these are real medical illnesses. They're mental, they have spiritual effects, but they're medical illnesses. And so you don't have to choose. Of course you pray, and of course you get whatever help makes the most sense for you.
I will also say there is definitely an increasing number of Black pastors, I know in our community and in larger urban communities around the country, who are definitely advocates of mental health care. And so it's a growing area, and you know, it's opening up. So I would say persistence is a good thing, and keep talking, and don't get discouraged.
Yep, you have a power that Dr. Hankerson and I don't have with our doctor hats on, which is we can quote statistics all day long or make pronouncements. But when somebody stands up and said, I had this, I went through this, and this helped me, it has an unbelievable power. And as more and more people do that, more and more people are going to realize, hey, it's not just me. Yeah. This affects everybody one way or another.
And I think, you know, it's increasingly clear that one of the most effective ways to reduce stigma around mental health conditions, and I believe especially in faith-based settings, is with contact with someone who has had a mental health condition, gotten treatment, had a positive treatment outcome, and then they share their story. And that really, that narrative, that sharing, that testimony, if you will, is really in line with the spiritual practices of our houses of worship. And so I think, you know, being persistent, sharing your story, and creating what I hope will be a groundswell of people sharing their stories will really help to move the needle in this area.
I'm going to move on to another kind of group of questions that deal with, the first one is, what are your thoughts on therapy apps like BetterHelp? I've heard mostly negative comments from providers and users alike, but we could enlarge that to talk about telepsychiatry, for example, and, you know, where we are, where we're all living right now. So Dr. Hankerson, you want to take a shot at that first?
Well, I must admit that I personally am not familiar with that app. I know that apps are becoming much more common. I am familiar with like Calm and Relax, and there are a lot of meditation apps that people actually have reported they enjoy using and that they find effective. And so I guess that's what I can say about the app piece. But in terms of telepsychiatry, I think telepsychiatry, at least to some degree, is here to stay. And I think that, you know, we've seen a huge demand for mental health services because of the grief and trauma of the pandemic, and because of the depression and anxiety really about people going back to work and reintegrating into society. And so I think that telepsychiatry is here to stay. And I think there are positives, and like with everything, there are areas of improvement. I think the positives is that as I see people in telepsychiatry, people more frequently come to their appointments. You can be at work and see your mental health provider. You can still have your, you know, be at home and have your kids there and not have to worry about childcare, all of which were barriers to people receiving services. The thing that I worry about are older adults and people who maybe lived in under-resourced communities who may not have access to stable internet connections. And how are we going to make sure that those type of telepsychiatric services are equitable and accessible by everyone? So I think that telepsychiatry definitely has increased access, but I think we just have to make sure that it's accessible to everyone.
Yep, agree. I'm also not familiar with a specific app, but I have a mentor, psychiatrist who says, I love self-help books, but I wish that everyone came with this little one paragraph introduction that said, please combine this with work with a person who's a mental health professional. And that may seem like a bit much. It's not because you need somebody to tell you what to do. It's because there's no book that's perfectly adapted to me or you as an individual. We kind of have to find the elements of ourselves. And as I say, we kind of write our own book in treatment, and we develop our own app. And so what we do is take tools and techniques and things that work for us and address our needs right now. And there are great things online. I agree, the self-relaxation, and there's different kinds of meditation, including Christian and other faith traditions that people can use, are great. There are apps for post-traumatic stress disorder, sleep problems, which a lot of us have. And when you get a good scientific technique that's been well proven, like there's one called CBTI, Cognitive Behavioral Therapy for Insomnia, a set of techniques that works, at least in studies, as well or better than medicines. And you can look in your app store and find apps that let you utilize that for yourself. That is fantastic. I'm like Dr. Hankerson. I'm also concerned, though, about we don't want to lose the power of a personal relationship and someone who knows you and you know them. And so I'm personally a little wary of an app that says, come, be with our company and we'll supply your therapy. I don't know how those work. But what I do know is you need a person that you get to know and trust and gets to know and trust you, that you have a personal relationship with, because there's nothing more powerful in mental health, in my opinion, than that relationship.
Thank you. We have a question here. Where are we with using genetic testing to see what meds would work best for someone?
And I feel like I'm at my board exams answering questions, so I keep waiting for
Very
Dr. Hankerson to weigh
very
in.
savvy Q&A. My goodness.
Well, you got a group of people who are living this. You know, many of us, we live this every day. So,
That's
and
right.
my wife and I, for example, we don't stop reading, and so we're always looking for new things. Dr. Morehead, you want to take the genetic testing one, since that's
Sure, and I will be subject to correction by Dr. Hankerson because I know some about it, but again, it's not a special expertise for me. I'm glad we have it. There are numerous companies that have developed these panels of tests where they have both liver tests about how your body metabolizes the medicine and how fast or slow it metabolizes the medicine. And then there are tests of things that are relevant to the brain and how your brain reacts to different things that relate to serotonin or norepinephrine or some of these other transmitters. And they are really intriguing, and occasionally I've found them to be very helpful, and I know people who've gotten a lot of help out of them. Most of the time, I got to say, just from personal experience and then looking at studies that have been done, although overall it can make a difference, a lot of times somebody has sensitivity to a lot of medicines and we don't figure out why from these tests. And I think the reason is that we may have, 10 or 20 tests on the panel, which is a lot, but we might need 100 tests or 300 tests to know all the reasons why somebody reacts the way they do to a medicine. So I feel like it's not 100%, but if you're having reactions to medicines and can't seem to find the right thing, it's a tool that can speed up the process.
Yeah, I mean, I'll just add that I think persistence is important, and I think, for example, with depression and thinking about depression treatment, if Dr. Morehead and I, if you come to our office and we prescribe you an antidepressant, only 1 out of 3 people with the first antidepressant that we prescribe are going to get better and return to their full, normal sense of life. But 2 out of those 3 people are going to need another medication or need to be something added on to that current medicine. And so, mental health conditions can be very difficult to treat. And so I think it's important for people to be persistent and to be aware that these are long-term illnesses. And while genetics offers promise, there's still a lot that we don't know. And we won't know, even with the availability of genetic testing. So it just really does take a kind of a long-term approach and perspective.
So important. I got to say a little word about that too, because this is such a biggie what Dr. Hankerson just articulated. And I think of it again like, say, another medical problem. Say you have high blood pressure. You go, there's 50 high blood pressure medicines. You try one, it doesn't work. What do? Well, you just go back and say it didn't work and try another one, right? And same thing with depression. Now, meanwhile, you're suffering with depression or your mental health condition, anxiety or addiction. So we're not talking about just sitting and waiting for nothing, but yeah, you have to give something a good try to know if it worked or not, to then say, okay, I know I'm ready to go on. But then when you do, it can be, 2 or 3 or 4 medicines. And sometimes internally, I've said to myself, oh my goodness, I'm afraid nothing's going to work. And then the next time something lights up and it's the right combination for somebody. So couldn't agree more about persistence.
Okay, let me go to the next question. My son has priapism so many times due to antipsychotic medications that it has left him with fibrosis of the corpora cavernosa. The only thing that will help him is to have an implant. No one has been able to get through to him on this. Any suggestions? At this point, he is on 100 milligrams of loxapine. He is better, but still has psychosis. Dr. Morehead, you want to chew on
just to say thanks for the question and thanks for sharing something like this, which is a personal thing to talk about. But on the other hand, in my mind, part of what it illustrates is these decisions are so complicated and people are so different. I mean, to my knowledge, with antipsychotic medications, priapism, which is an erection that won't go away, is not, usually the problem is in the other direction.
Opposite, right?
Yeah. But there are medicines that are known to be associated with priapism, and regardless of what the statistics say, all doctors see this too, which is, well, on paper you shouldn't have this, but you have this. And I have learned the hard way saying, well, there's no way you could have this. I've been proven wrong so many times. I never say that now. I don't know 100% if the medicine is causing X, Y, and Z if I can't find it in the data. But if there's an association over and over, and it looks like every time you go on a medicine like this, you have this side effect, then we'll work with it. We'll take it at face value and work with it. And then it is so hard because it's hard to know, well, what's really causing this, and then what do we do about it? And I think this is one of those problems where somebody may need special expertise, and it sounds like there's been consultation, maybe with somebody like a urologist who's an expert on the medical side of it, and just persistence of I've been in situations for years. We worked on it, and you know what? It's just when you're ready to give up is often when you're surprised by something in a good way. So I sure don't have the answer for this question, but I sure know don't give up.
Yeah, I completely agree, and I think it brings up an important point about side effects of medications and the importance of being in communication with your provider. I echo, Dr. Morehead's comment about how vulnerable that was and how courageous that was of you to bring that up, because it's such a sensitive topic. It's important to be clear that all medicines, whether they're for high blood pressure, diabetes, cholesterol, or mental health conditions, all medications have side effects. Psychotropic medications can have side effects that cause impact your weight, that impact your sexual function, that can decrease your sex drive, that can cause priapism. And so I think the important thing to take away from this is to be honest and open with your provider about what side effects that you're experiencing, and work with him or her about ways to address the side effects while at the same time trying to relieve, those symptoms. And so again, this goes to our point about being persistent, because it's kind of it's a two front battle. You have to try to treat the mental health condition, and then sometimes you have to navigate the side effects as well.
I just want to say how pleased I was to see the question, because it's,
Yeah.
there's so many times when we're in a NAMI family group where, you find out it's really important to be able to articulate these things when you feel like you're so cut off and left alone and nobody else has this issue. So I appreciate the openness and the candor. We have another question. How often are you seeing clients who are at such great risk for deterioration that they would most likely need a guardian? They cannot care for themselves in a way to even meet their basic needs. LA County has a pilot for conservatorship with the homeless population so that the appointed guardian can ensure the client will get a monthly injectable, with the hope that clients will gain insight and transition to more meaningful services. Comments on this approach?
This is so difficult. I will gladly yield for others. I know as a family member and if somebody's worked with NAMI for a long time, Doug Beach, I think has a lot of expertise in this. So I'd be curious about both of your comments. To me, it's a very, very difficult medical issue, but again, probably I am kind of simple. I go back to thinking, okay, what will we do in some other medical situation? Because often that seems more clear. So in a medical situation where somebody comes in and they're not able to respond as their normal selves, right? Like somebody's been in a car accident and they're knocked out and they can't tell us, is it okay if we treat you? We don't want to treat anybody against their will. But if they're not able to tell us, we make the assumption that, well, almost anybody's going to want treatment here. And until we know otherwise, we're going to treat them. And then if this situation goes on, get in contact with their family as soon as possible. The appropriate family members will step in, or if there's no family, then maybe as a last resort, the legal system. And I actually have come to feel the same way about mental health conditions. There are conditions that part of the condition is I've actually experienced this. I've noticed, I've dealt with mental illness, but I've also noticed having a few surgeries coming out of anesthesia. I think I'm fine. I'm great. I'm flying. Let me out of the hospital. I am not fine and great. And a few days later, I know that. But at the time, and here I've been to medical school, I've seen people in this state. At the time, I cannot look at myself and say, there's something's missing from the way I'm normally am and act. And so we know that with many mental illnesses, they can be severe in a way that keeps me from realizing this is hurting me. And I think if I'm not my normal self, it's appropriate for family and even the legal system, if necessary, to step in as a last resort to help people get treatment till you get to your normal self enough to say, okay, this is worth it for me or it's not. And then at the same time, the excruciating part is it really it hurts, and it's sometimes emotionally traumatizing when people are forced into treatment, forced into the hospital, or forced to take a medicine with a shot. It feels terrible. Many people feel humiliated, understandably, and don't want it and feel scarred by that. So it is, we get in these situations where it's like, boy, we don't have a good option here. It's bad just to let somebody go on in a state that's not normal for them. It's bad for their body and brain. But then on the other hand, to have for family or the legal system to have to force treatment as a last resort and has a price. But for me, I've come to see mental illnesses are so bad that if necessary, it's our last resort. But again, I'd be curious about other opinions. This is a good question.
Dr. Hankerson?
Yeah, I certainly have seen the trauma of forced treatment, and so this is a challenging and delicate situation. I do think that it brings up one of the challenges of treating chronic long-term mental health conditions such as schizophrenia or other psychotic illnesses or bipolar disorder. And so I think that just in terms of a comprehensive treatment, I think that part of any kind of comprehensive outpatient treatment, especially when there's been challenges with engagement or compliance, should be engagement with the family. And I don't mean to be sounding like a paid advertiser for NAMI Family to Family, but I think that there's power in being connected to family members who have experienced what you have experienced. There's power in that. There's advice that cannot come from medical providers because we have not lived it, and there's support. And so I think that one of the best strategies or things that I could encourage you to do is try to see if you can connect with a NAMI to family to get people's perspectives, pros and cons of that, because I've heard people from family to family who have been adamantly opposed to any type of forced mandated treatment. And then I've heard the opposite argument. So I think, trying to hear both our sides of the picture are important.
I guess what I would add is that, we've got two types of circumstances here. We mentioned the homelessness, and that's where people have really probably been, for the most part, cut off from family members or maybe close friends, and may or may not have. And then you have people who are living who have more support systems around them. But in both cases, I would say that one of the things that I see that's hopeful is more of a team approach for a person. I find it almost impossible as an individual to care for somebody with serious mental illness day after day, 24/7. Whereas if you have several people around you, and in the case of, we're doing this in San Antonio with our case managers, our outreach workers, community health workers, therapists, people on the ground who are going out, approaching people in tents and shelters. I think that, and building up that relationship and that trust. So one of the things, to go back to Amador, that he talks about is the relationship and the trust. Mm-hmm. So, that is at the core. I've never seen a lot of good happen where there's a broken relationship, there's no trust, and you basically mandate somebody to go to care. That's so we do have cases just like Dr. Morehead and Dr. Hankerson have mentioned, where people are so ill that it almost takes a public conservatorship, if you will. And that's what our mental health court is. And that's what Judge Kazin in Bexar County does. So a lot of discussion here. I'm going to go on to the next. This is a question. When someone has refused TX and prescribed education for years, but has self-medicated with drugs and alcohol, is there any way to distinguish between the true mental health problem from the substance abuse induced symptoms in order to help them when they finally do seek help? So we have this co-occurring disorder question. Dr. Hankerson, you want to take that one first?
Sure. So it can be difficult to kind of tease out which is first. This can be kind of a chicken and an egg type of scenario. We know that when people use substances like alcohol, it can cause mood disorders. It can cause psychotic disorders. And we also know that sometimes people, when they have depression or anxiety or other mental health conditions, they can use substances. So comorbidity is very, very common. And so I think it's important. I think a key message from today is to really take a holistic approach and to really take a team-based approach and to treat the entire person. I think sometimes, even as psychiatrists, as mental health professionals, we tend to separate the two when we should be looking at the picture holistically. Because someone could be, I often see people, one of the people I saw this past Monday said, Doc, I I smoke weed every night so I can sleep, And so part of why she's smoking marijuana is because she's anxious about the eviction notice that she has. And so I can't tell her to just stop smoking marijuana without looking at the entire picture of her social circumstances, of her anxiety symptoms, of what kind of caused her current depressive episode as well. And so I think the important message is to treat people holistically. And through that holistic treatment, hopefully can get at both the mood disorder in this case, as well as the alcohol use.
Quick plug for 12-step programs here, even though this wasn't what the question was about. Alcoholics Anonymous, Narcotics Anonymous. Somebody in the chat mentioned Celebrate Recovery, which is just general self-help groups in churches that use the 12-step model. If you have substance abuse problems and you're willing, there are free 12-step meetings in virtually every community multiple times a day. There's nothing like it in mental health where I can just say, hey, this is good, just show up as many times as it's helpful. Now, it's hard to get people to show up. Some people say it's not for me, but it's a huge, huge resource.
I'm going to go to the next question here in just a second, but I also want to call everybody's attention to the chat box and to the questions. There are a number of comments that are coming in from the audience, many of whom have experience with the topics that we're discussing, and those are always worth reading and listening to. I know a lot of the people personally, and their input is always great. I'm going to go to the next question. I've been told that clozaril is the gold standard in treating schizophrenia. It has been for my son after he tried every single other available alternative with no success. But I've also been told that clozaril may stop working at some point, and that since it was the medication of last resort, there will be no other medication options. Is this correct? Are there any medication breakthroughs that may offer hope in this situation? Dr. Morehead?
So I'll try to be brief because I bet Dr. Hankerson can add something in this regard. Again, not my number one expertise, although for a time I was the number one prescriber of clozaril in Austin, which I find somewhat ironic because I didn't start that many people on it, but I replaced the doctor who started a lot of people on it, who was a really great psychopharmacologist, a great prescriber. And so I did see all these people whose lives were changed by clozaril. So yes, if people haven't tried clozaril, then they haven't tried everything. I ask this question every time at psychiatry conferences. What do you do if clozaril doesn't work? Because it doesn't work or doesn't work completely for everyone. The answer is kind of a moving target because there's always new possibilities coming up. I looked at it recently. There is some evidence that you can add another antipsychotic that works in a somewhat different way. And it's not that it works for everybody, but it can give additional benefit to some people, is what it's looking like in the studies. And then there are new treatments coming out. There are a couple of relatively new antipsychotic medicines, and they all work in a somewhat different way. So even if the only thing that worked 10 years ago was clozaril, it's possible that one of the newer ones might work. And I sure wouldn't take somebody off clozaril just for no reason if it's working. But if it's not working, don't think that you're out of options. One of the great things about mental health is, okay, we don't know what's going to work, but you're never, I should knock on wood. I don't want to jinx this, but in general, I bet Dr. Hankerson would say the same. As much as people have been through, it's incredibly rare to totally run out of options because there are always new things coming out. Okay, I wasn't brief, but over to you, Dr. Hankerson.
But it was comprehensive. And I'll just add to that. And that's a fascinating statistic, Dr. Morehead, that you're number one prescriber of clozaril. I'll just add to that. I think just emphasizing this persistence, right? So I think that's a theme that has come up. Schizophrenia and mental health conditions can be very chronic. And even if someone is doing everything right, meaning we found a dose of medication that works well, their symptoms are gone, their symptoms can come back, even if they're taking their medications regularly. And so I think it's important to realize that no, just because someone has symptoms of recurrent on Clozaril, that's not the end of the story. And so there are definitely, other treatment options, as Dr. Morehead mentioned. And I also just want to emphasize the holistic approach. Many antipsychotic medications can cause weight gain. They can increase risk of diabetes. And so it really underscores the importance of people thinking about exercise, thinking about other medical conditions, and really looking at a total, kind of wellness picture as a part of a treatment plan.
Exercise helps schizophrenia. 5 studies I saw in one review. Really, really remarkable.
Yeah.
Okay, we're down to the last 5 minutes. I'm going to do hopefully 2 real quick ones here. How can you increase your serotonin and another brain chemical naturally besides exercise? Any special vitamins? I take Prozac and Lamictal. Is there a method to measure how short you are on serotonin?
Dr. Morehead,
they're going to give me one last chance to be brief, and by golly, I'm going to take it. Well, first of all, often a more serotonin function seems to be better in many illnesses like anxiety and depression, and I'm in those categories, but not always. So the proof is in the pudding. The proof is in what helps. There is a vitamin or additive called methylfolate that's been shown to help our production of serotonin and also dopamine and norepinephrine, and shown good results as an add-on for major depression. So you can talk to your doctor about that, or if you trust the company, you can buy it over the counter as well. That's methylfolate, just a form of the vitamin folate. There are a list of foods you can try to increase serotonin. I've never seen if that's, you can increase serotonin in the body, but there's a blood-brain barrier. So is it going up in the brain? I don't know, but most of the foods on that list probably won't hurt you. So I would feel free to Google that as well. And then a third thing I would say, not just to increase your serotonin level, but for your health in general. Social support and faith communities are one of the best ways to get that. Is huge.
Dr. Hankerson?
No, I completely agree with that. Nothing to add to that.
Okay. One last comment here and question. I am an Iraq War veteran, retired military nurse, and also a mental health nursing faculty member at a local university in San Antonio. With yesterday's tragic killings of military and civilians in Afghanistan, what do you suggest I say to my fellow veterans who are so upset? I also teach nursing with other retired veterans. I could say, how are you doing? But I don't want to trigger an enraged response. I know that I was triggered with the news and had to turn it off. What are your thoughts?
Let me just say thank you for your service. Thank you for your service to this country, and thank you for thinking about your fellow veterans. The events in Afghanistan yesterday were horrific, and they certainly were triggering. And I think even the withdrawal over the last several weeks, we've seen the numbers of veterans calling the crisis line skyrocket over the last several weeks. And so, tragically, I expect that number to even go higher after the events of yesterday. And so I think that this is certainly triggering a lot of trauma, understandably so for veterans, and a lot of questions about folks who served in Afghanistan, whether their service was worth it. And so a lot of emotions are being stirred up. So I think one thing that you can do is just be available and be present to the degree that you feel like you have the emotional capacity to be available and supportive, and encourage people, veterans, to seek out mental health services. I think even though that the VA healthcare system has done a wonderful job trying to address the tragic rise in suicide among our veterans, there's still a tremendous amount of stigma, as I'm sure you're aware, especially among men veterans. And so I think one thing that you can do is really try to create spaces where people feel safe and allow them to share their vulnerability and encourage them to get help, if they need it.
Thank you. You know, these sessions are always fascinating because you never know what questions are going to come up. And we're out of time. I really appreciate the audience for asking a lot of difficult questions and things that, it's nice to have a place to go and just talk about this and get some educated response. I want to thank Dr. Hankerson and Dr. Morehead. They didn't have to do this. They didn't have to say yes to coming to the conference and being part of this panel. Thank you many, many times over. There was a reason why you were invited, because you both are just outstanding, not only in your practice, but in your communities. So thank you for all that you're doing. I want to tell the audience that's listening in that we are going to take a break now for 30 minutes to allow everybody to grab whatever form of nutrition you need to grab or take a bio break. And then we're going to reconvene at 1 o'clock, and there will be another set of workshops along the 4 different tracks. Please stay with us the rest of the afternoon. You're gonna love it. They're all great workshops. You can't pick a bad one. So I want to thank everybody for being online today and for being attending Pathways to Hope.